Hello, everyone. Welcome to the Ophthalmology Business Podcast. We develop your ideal practice with the help of other doctors and experts. Topics include marketing, management, leadership, recruitment, HR, mindsets, and more. I'm Dr. Omar Shakir, one of the hosts of this podcast. Every listener of this podcast is welcome to join the Ophthalmology Business Academy at www.obacademy.org. The membership's on us, and it's our gift to you. Today, I'm really excited to talk to Tony Burns. He's the Chief Strategy Officer at IOR Partners, which is a company that's been rapidly growing in the office space surgery space. Our topic today is going to be updates for Medicare and just general overview of where IOR Partners is going. Welcome, Tony Burns.
Thank you very much. It's good to be back.
So you were on this podcast last time. You gave a beautiful overview of the company and gave us a little bit of your story. I want to first jump right into why you got into ophthalmology in the first place, what that story is.
Sure. So largely my background is ASC development. I got into the space late 80s, early 90s. Like most people, I started off in a hospital system. And pretty early on, it was evident to me that an ambulatory surgical environment offered the physician a much greater control over the delivery of his patient care, and that appealed to me. So I started developing ASCs. First it was a single specialty, and that did start with ophthalmology. And then later on, I brought in multi-specialty. But for the most part, with the sheer volume of cases that are done in ophthalmology, I ended up really kind of focusing in that area. So we between the 90s and through the 2000s, I developed about 200 ASCs.
Incredible work. Now, you also have an MBA, right?
I do.
Where'd you get that? And what was your reasoning behind getting an MBA?
So I started off. I went to the University of Utah for both grad and undergrad, and I was actually going to be a doctor. And my father at the time decided that it was the '90s and all the managed care stuff was going on. So they didn't. He didn't think that going into medical school was a good idea. So he told me I could either pick law school or I could pick business school. And he was a lawyer, so I picked B school. So that's how I ended up with an MBA. The program I had didn't have an MHA at the time, so I have an MBA with an emphasis in healthcare administration.
Got it. Yeah, for our listeners that are interested in the business aspect, it's always good to hear stories as to how people got into business school and why they did it. Now, there's been a lot of developments. Your company's been rapidly growing and ever evolving. Recently, the big news item from the Academy has been the Medicare ruling on office-based surgery. Can you update us on what does that ruling mean, and what does it mean for your company and surgeons?
Yeah, sure. So a quick history of that. Medicare originally decided to look at office-based ophthalmic surgery in 2015. They did a request for information back then, largely based off a study that was conducted at Kaiser Permanente, and they did a request for information. At that point, most of the feedback was pretty negative. There just simply wasn't enough safety data or enough widespread safety data, I should say, that called for it. That's about the time that IOR Partners started doing cataract surgery. We originally started as a company called ISS that was created to do mostly ICLs in the office. Then we went on to RLEs. And then about 2013, 2014, we started doing cataracts in the office. We figured out methodologies for reimbursement. And we started kind of in earnest doing cataract programs about 2016, 2017, right around when this occurred. We had submitted the proposal for Medicare to do the revaluation of office-based cataract surgery, glaucoma, retina, and oculoplastics. We had originally submitted it to Medicare in 2020. We submitted 12,000 cases, had great data on it, felt very, very confident about our proposal. And then, of course, as everybody's aware, COVID hit. That put the stop to all programs that weren't absolutely necessary at the time. And of course, these are elective procedures, so we were put on the back burner. We resubmitted the proposal in 2022, and this time we had almost 30,000 cases, and made the final rule. Made the proposed rule for 2023. That went out to comment in the fall of 2022. got a tremendous response. We had an 87% more positive response towards office-based surgery. Of course, we had many more facilities doing a lot of cases then. We did not make the final rule, and the reasons that were cited for that is that the societies wanted a bit more information, more detailed information on the safety data. They wanted to know the proposed rollout for accreditation, governance, and coverage. So we have since worked with both Medicare and the societies, specifically the Academy. We have provided them with the detailed safety information. At this point, we actually have data, published data on about 50,000 cases. We presented a paper at the last Academy this last November in San Francisco on almost 50,000 cases. Had the information that Medicare requested. We also have done several things with accreditation. We presented the rollout program for accreditation and governance that we suggest for all of the office-based suites, as well as we have partnered with the Joint Commission to roll out a specific program for office-based ophthalmic surgery. And let me come back to the definition of office-based surgery. So the definition of office-based surgery is any place a physician performs surgery outside of another licensed facility, such as an ASC in a hospital. And the reason why that's important is because an ASC or a hospital has a single standard for all specialties. Once you're licensed to do surgery in one of those facilities, any specialty can come in there. So the standard for that has to be the highest possible standard. The beauty of partnering with somebody like the Joint Commission for office-based ophthalmic surgery is we can modify those standards specific to the specialty. So we carry the same standards in office-based surgery to keep the patient safe as an ASC or a hospital does. We just don't carry all the additional standards that don't apply to us. And we could cite many examples of that. But when we made this partnership with the Joint Commission, what we were able to achieve is we were able to achieve something that is more efficient, it's more specific to the specialty, and therefore we believe that's why we're getting a better adverse event rate and a better outcome rate.
That's great. And for those listeners that aren't familiar, I don't know how you wouldn't be familiar with Joint Commission, but they were formerly called JCO, right? The Joint Commission on Accreditation of Healthcare Organizations, and have since been rebranded as the Joint Commission now. And Joint Commission doing still hospital work, still ASC work, and now a very big part of office-based surgery. Right. So to summarize that, so Medicare came back and said that they're basically going to kick the can down the road on making a decision, right? They didn't flat out say no.
Well, right. So what has happened is we resubmitted the proposal after we had met the issues that they had cited, and this time was a little bit different. We didn't ask for a specific date on the revaluation, and what we're asking for, just for clarity's sake here, is that we're asking for additional RVU value, relative value unit value, to be added to what's called the practice expense RVU, which is the portion of the professional fee that is reimbursed for the expenses that are incurred for you to do business as a physician. Of course, when you bring the surgery into your office, you incur a lot more expenses to do that. So we're asking for additional RVU value. So we resubmitted the proposal with all the cost data, and really after lots of discussion with many of the entities, including the Academy, what we're asking for is parity for the ASC value. And so whatever the national ASC GPSI or the local ASC geographical price indicator for any specific area, we're asking for parity of that fee. And the reason makes a lot of sense. It's in everybody's best interest to do that. As we know that anytime it is demonstrated that we can do surgery cheaper somewhere, those fees tend to go to that level. And the fact of the matter is that the expenses to do office-based cataract surgery are exactly the same as they are in the ASC. Same capital equipment, same staffing, same supplies, same instrumentations, implants, etc. The only difference is the building. And the building, when you amateurize that over thousands of cases and dozens of years, really reflects very little of the expense. So we've asked for parity in the ASC GPSI. And I think for the most part, at least verbally, they've agreed to that. We asked for revaluation to occur at the next time that the cataract codes were being revalued. We didn't ask for a specific date, just whenever they were doing that. And that seemed to resonate with Academy. They liked that approach. And I have to be careful how I talk about it here. Academy does not partner with third-party vendors, which is what we are considered. What Academy has agreed to do is work with our clients that are Academy members to look at data, both safety data, outcomes data, and cost data to when this is revalued, when they take it through the rug. So I think we've made a lot of progress in those areas.
That's great. So, but does that mean that we can't do Medicare cases in the office today? Can we get paid for doing a Medicare case in the office?
Boy, that's a fantastic question. And we hear that a lot. And it causes a lot of confusion in the industry. And the answer to that is absolutely yes, you can. We have ways of working with Medicare to get reimbursement, currently to get reimbursement for office-based surgery. And let me give you a little bit of background on that. When people hear that Medicare doesn't reimburse for office-based cataract surgery, when that claim is made, what the statement is saying is that Medicare has not set a national level for reimbursement of office-based cataract surgery, and that is absolutely true. There are two ways to get reimbursed when you're submitting claims. You have what's called a national coverage determination and a local coverage determination. In Baltimore, Medicare sets national coverage determination, and that is on primary codes. So 66984 cataract surgery is a primary code, and it is decided, the reimbursement value of that is decided on a national coverage determinant. What we do is we work with the local MACs. There are 8 local MACs that we work with in 12 jurisdictions, and we work within that system to do what's called local coverage determination. So we negotiate with the individual local MACs on secondary codes. These codes are built in addition to the primary code on the professional side, and we work with them to negotiate additional reimbursement above and beyond the pro fee. So both statements are technically true. Medicare does not recognize office-based surgery, office-based cataract surgery on a national level, but we do get additional reimbursement with working with the local MACs.
And that's happening in every MAC?
In every MAC. Right now, as it sits, IOR Partners has about 125 OBS suites that are in either currently operating, under development to some degree. And this is in 36 states, which covers all 8 MACs, all 12 jurisdictions. So we have active claims going in right now in every area. When we spoke with Medicare about our outcomes analysis, we had to let them know how we were being reimbursed. And we told them the methodology, and they agreed. I mean, they didn't agree with it. They just said, okay, that's fine. We have a white paper that has been written by a DC-based law firm called Hogan Lovells that documents and illustrates how we work with every MAC. So we're very open about our approach on this, and all this really is a means to an end. What our movement here is to get office-based surgery, office-based ophthalmic surgery at the same standard of care as ASCs and hospitals. We all know that the patient population demographics are growing. Every baby boomer will be Medicare age by 2030. That creates a whole lot of surgery. And currently there isn't enough operating rooms and there aren't enough physicians to be able to address the onslaught of patients that are coming. And if we don't take steps to have an alternative methods to address this patient care, we're gonna have people that just simply don't get care. And so what we're trying to do is we're trying to establish a standard that can be applied in every community, rural, underdeveloped. Any physician who has an office and space can perform surgery in his office. That's what we're trying to do.
So are there examples, twofold question here. Are there examples of other specialties where office-based surgery is recognized by Medicare and does get a separate reimbursement? Is it just that ophthalmology has fallen behind? Why has ophthalmology not been a part of that if that's the case in other specialties?
Yeah, great question. I think there's a couple answers to that. First of all, the first answer is yes. ENT, OBGYN, cardiology, spine, urology, all of these specialties have procedures that are performed OBS, or in some cases it's called OBL, which stands for an office-based laboratory. And I think ophthalmology is the first quote sterile procedure that is being performed in office, that will be recognized by Medicare. So there is certainly a leap in the sterility and aseptic technique for cataract surgery compared to an endoscopy. If you're doing a GI scope, or if you're doing a sinus procedure, those are considered clean procedures. These are sterile procedures. But at this point, we have answered the safety question. We have got just reams and reams of data. Like I said, we published this last study at Academy in November of 50,000 cases, and that's just a massive cohort. That's a lot. So we've answered the safety question, and I think that what this is going to do is it's going to open the door for all the other specialties. We saw the same thing happen with the ambulatory surgery centers. These largely started as ophthalmic centers, and then, as I mentioned earlier, they branched out into multi-specialty. And as everybody knows, it's the current standard for everybody if you're doing outpatient single-day surgery. And we think the same thing's going to happen. We believe that it's going to be a better environment because, again, you can cater the standard to the specialty that you're dealing in. So, we're right now we're launching some beta sites with office-based hand surgery, carpal tunnels, trigger fingers, things of that nature, and the standards that we're going to employ, of course, are going to be more modified and more specific to the surgeries that they're doing.
That's incredible. We would love to see this concept, take over other sterile type procedures. Just quickly on the topic of the safety data, because I remember seeing the presentation. If I remember correctly, the endophthalmitis rate came in lower, and I want to be careful how I say this because we don't want to make a claim that might not hold to clinical trial type evidence. But from what I remember, the endophthalmitis rate came in lower than what's been published before in ASC data. Is that correct?
Yeah, and that is
How would
correct.
that be the case?
Yeah, I have to be careful as well. So I think we've got a couple things going here. First of all, our data is what we like to call real world data. So we have every case from every center from case one. So this is data that has been collected as we've been going along, and we have a unique cohort because we have the entire patient record in one spot. So there isn't any degree of separation between your office and the ASC. Everything is one chart, which gives us a very unique perspective. So I think our data is probably a bit more accurate. And again, we have to be very careful of what we claim. But certainly that makes intuitive sense that if everything is in one chart, you're going to have more comprehensive data. I think that anecdotally, the reason why is because as you know, when the patient is in one location from beginning to end, everybody takes a bit more ownership in this. Everybody has a role and a vested interest in that patient doing well. And if your staff member has worked them up preoperatively, is walking them through the suite, has to see them postoperatively, they're simply a little bit more cognizant of the actions they're taking. It's relationship driven. Of course, obviously that's anecdotal. I can't quantitate that, but I can say that our outcomes data is fantastic, and I think it's going to continue to be so.
Yeah, and I totally agree with you there, Tony. As you know, I do some office-based surgery, and I see the buy-in of the staff as one of the biggest perks for my practice. I know in this current generation of employees, one of the most common complaints is there's just not a lot of work ethic and buy-in in the process, especially in healthcare, which is so important. And I think you guys do that well, which is to give buy-in to the whole office.
Yeah.
Now, you discussed reimbursement in a Medicare setting. Are you getting reimbursed by other insurers as well? And how does that work? What does it look like?
Yeah, so we get reimbursed by all the modalities, Medicare Advantage, commercial plans, managed plans, and we have to employ, as you can imagine, until Medicare regulates the industry and puts it under, a single enhanced professional fee. The different payers tend to treat these differently. So it's really hard for us to say that we employ this method in this case because every payer treats this differently. Right now, the last time I counted, we were working with 1,200 different individual payers. And they all like to treat this a little bit differently it depends on what their internal capacity is on the methodologies that they have to work with this. But what we do find is that most of them like working in this environment once they understand it, because it ultimately ends up saving money, not necessarily because we're saving them on facility fees, but because there's no pre-op testing usually. As we've talked about in the past, a vast majority, 98% plus of our cases are done without an anesthesia provider, which was something that was an unintended consequence. It just ended up going that way. The physicians prefer it. That was not an IOR Partners initiative. It was physician led. And that reduces cost. You don't have to get pre-op clearance, which saves a lot of money. You don't have to pay the anesthesia provider themselves, which saves a lot of money. It also saves a lot of time. So overall, if you get a, 10 to 15% discount on every cataract, retina, glaucoma procedure that's done, that's a substantial amount of revenue. And so payers love it. So yes, we've worked with all of them. And I just want to, as long as we're talking about insurance companies, I wanted to touch back real quick on the safety issue. One of the other things that I think we should probably mention is that we have a data sharing agreement with OMIC, and OMIC has agreed to cover the office-based suites that are IOR office-based suites from the first day of surgery, because we are able to demonstrate that we lower the risk profile. So if the other malpractice carriers and if you can't demonstrate that you've got policies, procedures, and general governance like IOR Partners, the malpractice carriers do not cover you until after you've achieved accreditation, which is a post-surgical accreditation. So it takes 3 to 6 months after you start during surgery to achieve that. With our systems, we're able to get coverage from day one, and that's because we've demonstrated it's a lower risk profile.
How does that accreditation work? Is that something the practice would have to do on their own, or is that something that you guys will help the practice obtain?
Yeah, it's something that's part of our service. We used to not insist upon it when we very first started out, but as we've gone along, it's just evident that we have to regulate this industry and make sure everybody's safe. And accreditation, people get accreditation and certification confused. Certification is typically a physical survey that occurs before you start doing surgery in a case for like Medicare. Accreditation is a procedural survey in which they have to look at peer review, they have to do chart review, they have to look at how you're actually treating your patients. And in order to do that, you have to have performed surgery. So usually what we do is we set up the governance structure, which is the basic infrastructure of how to run the center. It includes the policies, procedures. It includes the forms, how basically you're going to treat the patient. We implement that first. Then we start doing surgery under those conditions. Then we will apply for accreditation. As soon as we have enough case volume to submit peer review, chart review, things like that, then we will apply for accreditation. And so far, we've got a phenomenal accreditation rate. We've never actually even had a second revisit on any of our accreditations, and that's one of the reasons why we partner with the Joint Commission. Is that we wanted to make sure that we were in lockstep with a recognized leader of the industry to make sure that we were doing this correctly.
Yeah, but nothing stronger than the Joint Commission accrediting your facility. One of the other questions I get asked is, why are so many surgeons rushing towards this? I mean, ASCs are great places to operate, and we've been doing just fine in surgery centers and even hospital outpatient surgical centers. Yet I see so many practices and big practices sometimes converting to office-based. I have hosted some of them in my own center. What do you think accounts for that growth and that conversion to office-based surgery?
Yeah, I think there's several reasons for that. On the side of necessity, I think a lot of ophthalmology is struggling for surgical time. Last week, I visited a center in North Miami Beach in which they shut down the ASC 24 ophthalmologists were doing surgery in this surgery center. They had some urology and some ENT and some pain management, but by most part, it was 80% ophthalmology. And they shut the center down because they couldn't find anesthesia coverage to cover the cases. So they literally closed the doors on the center. Now that's obviously a very dramatic circumstance, but we run into guys all the time that say they're just struggling for OR time, because the fact of the matter is, other specialties simply make more money in the ASC environment. I mean, I still have a company in which I do ambulatory surgery centers. Myself, I don't put any ophthalmology in the ASCs anymore. I'd much rather have spine, ortho, and cardiology, because I can make a lot more money on those than I can on ophthalmic procedures. So I think that you experience a lot of that. They get displaced by other specialties. I think the other reason is more out of just, it's a better place to do surgery. I think the patient experience is better. I think the physician experience is better. We can turn a relatively small space, anywhere from 500 to 1,200 square feet for one or two ORs, into an operating suite, in a relatively short period of time, 4 to 6 months from when we decide to do it, we could be operating. We're not waiting for a license because we already have the physician's license. As soon as the equipment, supplies, staff, etc., is all ready to go, we start doing surgery. So we can get a physician to revenue in a very, very short period of time, 90 to 120 days. And the ultimate cost to get going is about 10% of what an ASC is. Certificate of need laws are not required because, or not applicable, I should say, because certificate of need is an application process to request an additional license. We're not requesting an additional license. We already have a license. So certificate of need doesn't apply to us. So it really is a system that is much, much more geared to this specialty. It's just a lot easier to do. And again, back to my original statement, it gives the physician a much larger degree of control of how he can care for his patients, which is the ultimate benefit.
If I'm a prospective customer and I just had that conversation with you, I'm all hyped and excited to do this, and I want to get going in 9,200 days to revenue generation. How does that work? How do you do it? I mean, what do I physically do? This is so daunting for me as a practice owner, or busy with my own surgical schedule at the ASC. When I have that conversation with you and I'm energized to do it, what physically happens on day one? How do we get there?
So the first thing we have to do is make sure that the program is going to work for you. So the first thing I would request from you is basically a census of your surgical cases for the last 3 months, 6 months, so I can make sure that you have enough surgical volume to warrant this endeavor. I would also request a copy of the floor plan in the place that you're looking at putting the suite, because we have to make sure that you have the space, adequate space, to be able to safely perform this. Office-based surgery does not have square footage requirements like an ASC does, but what we have to be able to do is demonstrate that we can safely evacuate a patient. Again, that's a little bit different term because, as I mentioned, since we're under oral medications, the patients can typically self-ambulate. So evacuation of a patient in an emergency is much easier in an office-based suite than it is when a patient has an IV or is under general sedation. We have to be able to identify specific areas of your practice. We need, of course, a procedure room. We need a sterile processing area. We need a sterile supply area. And then we need a place to pre-op and post-op patients. So we have to make sure that we've got the areas to do that. If all that is in check, then essentially we come to an agreement and we move forward. Our timeline is roughly 90 days back from when your construction is going to be completed. So what we would do is work with your architect to design the suite, get together with your contractor to get a timeline and bids to build it out. We would look at what your anticipated first surgery day is. We would go back 90 days, maybe 120 days if it's a complicated build, and we would start laying out a timeline on how to get you there. We would look at every case that you're going to do. We would go through those cases on a step-by-step basis. Off of that conversation, we would build the list for the equipment, the supplies, the instrumentation, the implants, etc. We would order that stuff in. In the meantime, we would be going through some training episodes with your staff. We will train your existing staff to assist you in these cases. We would identify a person for the sterile processing area, for the pre-post, for the surgical assistant and the circulating assistant. We would start training them virtually through bloodborne pathogens, all the OSHA stuff they need. We would send them some training videos. About 2 weeks before you do surgery, our staff will come out. We will set up the operating room. The things we're trying to accomplish there is, first of all, just set it up and make sure that everything is there. We want to make sure we have the space and the equipment works and that everything is there. That will also give us enough time to order anything that was either forgotten, lost, back ordered, whatever the case may be. Because again, we can only depend on ourselves in this case, so we have to make sure everything is there. 2 or 3 days before your actual surgery day, my staff will come in and train your staff. We will train them on aseptic technique. We will train them on protocols, operating room environment, that kind of thing. The first days you do surgery, we will act as your staff. So I will send 4 staff members out. They will fill the roles that I previously mentioned. And as your staff gains competency, my staff will switch places and second scrub your staff. So typically the pre-pulse person and the sterile processor get trained first. So we'll sign off on their competencies. My staff will back away at that point. Then the circulator usually gets trained in the third position. As soon as they're competent, we'll sign off. And then the last one is usually the surgical assistant. The last day that we are physically on site for the initial launch will be just in an observation point to make sure that everything is safe and acting smoothly. Then they will be signed off, and then we will support you throughout the duration of the agreement with things like just basic materials management, revenue cycle, which we don't call revenue cycle, we call it I-benefits. Because revenue cycle management is kind of a misleading term in our world, because when I say we will do your revenue cycle management, people think of what they know as revenue cycle management. And it's actually, as I mentioned, with the intricacies of how we build this, it's much more. So we define it as I-benefits, and we will manage that. We will manage all aspects of governance, all aspects of protocol, QAPI, as well as accreditation. Boy, that was a mouthful.
That's a lot. That's a lot. One last thing before I let you go, Tony. Obviously the largest piece of that financial burden would be the construction, it seems like, but acquisition of equipment is no small task. There's microscopes, phaco machines, and then the trays and all the instrumentation. I recently heard about a partnership that IOR struck with a GPO. Does that help in acquisition? Does it get us better prices? Can you tell us a little bit more about that?
Yeah, absolutely. So we've recently partnered with GPO for Eyes, which is an ophthalmology-driven community, and it now I remember my numbers, but I think we've got about 250, maybe even 300 members that have banded together specifically for contract negotiation with third-party vendors. So we can offer great prices just off the GPO on all the stuff. Of course, with our service, we work with the vendors to make sure that the pricing is adequate. The GPO pricing is phenomenal. They get great deals. If you're an IOR customer, you're automatically part of the GPO. That is part of our membership, but it also offers things outside of what your IOR would be. It offers deals on equipment, the click fee, the patient interface on excimer lasers, femtos, that kind of thing. It offers deals on just pretty much everything, diagnostic equipment, clinical stuff. So it's a really great benefit, and that's just something that's part of the deal.
So many different parts to this company. It's incredible what you guys have built there. Any parting words for our listeners about where you think this is heading? Are there any exciting developments coming up? Any changes that we should look forward to?
Yeah, I think that in the past, I'd say we're trying to build a movement here. I think at this point it's inevitable. I think that office-based surgery is simply going to be part of the vernacular of not only ophthalmology, but I think it's going to spread to other specialties pretty quickly. What we're doing here simply makes sense. There's a concept that we're competing against ASCs and hospitals, and that really isn't true. There are so many cases coming down the road that I think that just as ASCs came into the mainstream and they're now considered the standards, office space is going to be the same. There's enough room in this space for everybody. And I think that what we're going to find is not only are we not competing against each other, I think we're going to work really well together. A lot of our current clients are both ASC and OBS owners. And the reason is because they simply need both. It fits a different hole. And so I'm very excited about where this is going, and I look forward to seeing what we can do. I do want to mention that we've got some webinars coming up with the Joint Commission. Anybody is welcome to join that. You don't have to be an IOR Partners client or customer. And the specific topic will be achieving accreditation in an office-based suite. It'll be hosted by IOR Partners and the Joint Commission. And that is on January 29th and again on the 26th. Anybody can join that. If people want to see, get a peek into the world on how this works, that's a great place to do it.
A shameless plug for myself. I'll be talking a little bit about how our
Yeah,
practice
you will
went through Joint Commission accreditation, what our experience was like. Well,
Right.
thank you so much. So, this was our talk today on updates on office-based surgery and the Medicare ruling. Thank you so much, Tony Burns, for joining us. We appreciate all of your sage words and your wisdom.
Equimarketing, your key to a stellar online reputation. Book your free marketing strategy meeting with Ryan today. Visit www.obacademy.org/MSM/Ryan and take charge of your online presence.
I also want to take a moment and thank our listeners. We appreciate each and every one of you. We can't do what we do without you. If you like our podcast, please kindly share it with your friends and on social media as well. Don't forget to write a review on iTunes and Google Play, please. Your reviews will help other doctors and practice owners find us. Till we meet again, wishing you all an amazing week.